I am the rogue surgeon that was invited, but I do think that we work together, as a team, and this is critically important in the care of melanoma patients, particularly in this era where we have a lot of options that we didn't have before. So I kind of skipped a slide here, and I'm just going to pause because I see patients at a very different window than my fellows or my colleagues in medical oncology. I see a lot of patients with early stage disease. I see a lot of patients with late stage disease, but I see many patients in which melanoma is really a local problem that needs a local solution, which is me, surgery. And so, I think that's a really powerful way of managing cancer that we don't always appreciate when we're thinking about patients with late stage disease. But I think, again, these same tools come into play. In terms of how we treat patients, we usually have one slide on the margins of excisions, why we do what we do in terms of how much we cut out for the early stage melanomas. The long and the short of it is we do 1 centimeter margins or 2 centimeter margins. There's this little gray area where we don't know what the margins should be, and the long and the short of it is the more you can take, the better, but that has to be balanced with patient factors like, is it on their face? Will a 2 centimeter margin hole on their face be clinically meaningful in terms of decreasing local recurrences versus cosmetically cosmetic disadvantage to the patient? But beyond just cutting out melanoma, the other things we do is stage the patients and again, hopefully offer some curative therapies. So in my field, one of the most transformative studies early on was this MSLT-I study. This was in patients with surgically resectable melanoma, and this is when we began to use this tool of Sentinel lymph node mapping, and this was a prospective randomized trial looking only at patients with intermediate thickness and thick melanomas. So the thin melanomas is a data-free zone in terms of this trial, but this looked at patients, and patients either underwent upfront completion lymphadenectomy versus completion lymphadenectomy with sentinel lymph node biopsy. And what we found was that there really was no difference in melanoma-specific survival in either of these patient cohorts, in the intermediates or the thick melanomas. But if you think about it, all comers, only a small subset of our patients will have a positive node. So we really weren't necessarily powered to see that, but clearly the data suggests that there's no survival advantage in sentinel lymph node mapping for everybody. However, we do know that the information obtained from this procedure, relatively non-invasive procedure, is critically important. The prognostic significance of having a positive sentinel lymph node is incredibly important and really stratifies patients according to risk, and we can then manage them differently, and hopefully that aggressive management can subsequently result in differences in outcome. But it's more prognostically significant than Breslau thickness or ulceration, so that information is actually quite meaningful. The other question came up is, well, does the burden of lymph node disease matter? How much is, again, this is a occult disease, this is not clinically detected, but does the burden of disease matter? Is more tumor in the lymph node worse? And there's some suggestions that that is the case. The larger the tumor burden in the lymph node, the higher the risk to the patient. And so what do we do in real life? This is the sort of combined ASCO and SSO, which is my organization, the Society of Surgical Oncology. What are our guidelines? What do we tell our patients? And what we say is that in patients with an intermediate thickness or thick melanoma, sentinel lymph node biopsy is reasonable to suggest or to discuss. It's recommended is the language, and may be recommended for intermediate, may be recommended for thick, and considered for thin. I'd say, interestingly, and I'm going to get to the MSLT-II data in just a minute, many people were not excited about staging patients with thick melanomas. They thought the risk of distant recurrence was so high, why stage the lymph node? That has changed in the era where we're not necessarily doing completion lymphadenectomies for everybody, because that staging information is actually pretty valuable. So I would say, anecdotally, talking to colleagues in the field, I think people are much more interested in full nodal staging now when we're not always committing to a completion lymphadenectomy. So let me move on to that. So this was a nice study done by a multi-institutional group, but it was interesting. Sandra Wong is now the chair of surgery at Dartmouth, and this was when she was a fellow at Memorial Sloan Kettering. But they got together some data, this was in 2006, from several institutions, and they looked at patients who had undergone, patients with sentinel node positive disease who underwent immediate completion lymphadenectomy versus those who did not. And clearly there were some reasons, there were some embedded biases here, but they looked at the recurrences and found that the patients who did not undergo a completion lymphadenectomy actually did quite well, and began to ask the question, does every patient who has a positive sentinel lymph node need a completion lymphadenectomy? I will say the other data that factored into that question is the fact that when I counseled my patients pre-2017 about immediate completion lymphadenectomy, I said, 8 out of 10 times, there's going to be no more disease found at the time of completion of lymphadenectomy. Only 20% or 2 out of 10 of our patients were clearly obtaining benefit. So there was an unmet need to maybe not over-operate on patients who had a positive sentinel lymph node. And so several studies were underway. The MSLT-2 was the study that everyone was quite excited about, looking at, and I'll get to that in a minute, but this was a German study, the DeCOG-SLT. This was, failed to accrue and was closed early, so everyone was still waiting for the MSLT-2 data to come out. But this was published first, and there was, again, already a suggestion that there was no difference in distant metastasis-free survival or overall survival in patients who underwent immediate completion lymphadenectomy for a sentinel node positive disease versus those who did not and underwent close observation. And that's something I'm going to get to in the MSLT-2 data. When they looked at the subgroups, again, this was an underpowered study, but there was no clear difference between the patients who had a high tumor load versus a low tumor load, meaning the tumor burden in the lymph node, which I've showed you already, may have some prognostic importance. But the study we were all excited about was the MSLT-2 study. This was the prospective randomized trial looking at immediate completion lymphadenectomy in patients versus observation with nodal ultrasonography. So these are patients with a positive sentinel lymph node, and normally what we would have done is an immediate completion lymphadenectomy. That was the standard of care when I trained, and patients were randomized either to the standard of care, which is what we've been doing forever, or to nodal observation. So they underwent close observation, and they did undergo completion lymphadenectomy if they had progression in the nodal basin. So this wasn't that we just didn't operate on them. We just operated on them in a more nuanced fashion. And the primary endpoints were melanoma-specific survival, and then looked at overall survival and some other variables. And the key result that was really practice-changing for those of us who do surgery for a living was that there really was no improvement in melanoma-specific survival in the patients who underwent immediate completion lymphadenectomy versus those who underwent serial observation with completion lymphadenectomy only for progression in the basin. So there was no difference in this more sort of refined or nuanced approach. Clearly, there were differences in complication rates. In patients who underwent surgery, there was the complications we know are associated with surgery, such as lymphedema. So there was the morbidity of surgery, and clearly a subset of patients were spared that morbidity. There was unsurprisingly increased nodal recurrences in the patients who underwent serial observation. These were the patients that we consider salvaged by subsequent surgery, so that was no surprise, but it didn't really extrapolate into differences in melanoma-specific survival. So we could salvage them with a delayed surgery, and by doing so, by allowing them to kind of let the disease play out, we were able to operate more nuanced only on the patients who were gaining benefit. And when you look at the subgroup analysis, again, when you think about adopting these new changes into practice, we all wonder, well, are there groups that this doesn't apply to? Should we be doing something different in some of the groups? And really in the subgroup analysis, there was no clear group that fell out as obtaining benefit. And again, I would say this is a topic of conversation amongst many surgeons, and I still get texts and emails from friends asking what I would do with this sort of exceptional patient who had, didn't quite fit the comfortable criteria for this MSLT-2 approach. But it really did change our practice. At least at the Mass General, we actually met and decided, based upon the existing data, to adopt this sort of at a practice level. But I know that in the real world, and I present these kind of data to surgical communities all the time, the adoption is a little heterogeneous. The one thing I like to drive home, it's not that we're not operating on patients with positive sentinel nodes. We're doing it in a more nuanced fashion, and we're doing aggressive surveillance. So it's not that you either get surgery or we just forget about you. And it's only appropriate in patients who can do this serial observation. If your patient's going to, go to jail or move to Alaska or Antarctica, I guess Alaska, there's a lot of doctors, but somewhere where they may not get as much care, they may not be an appropriate person for this sort of surveillance type approach. And the other thing that's important to think about is that the management of a positive nodal basin, so clinically positive, has not changed. That's surgery up front. All that we're talking about in this MSLT-2 practice changes really has to do with patients with occult disease, patients found only on a sentinel lymph node. And in patients who present with palpable nodes, we do what we've done forever. We stage them, we confirm that this is tumor, that this is cancer, and then we operate on them. And we do a complete therapeutic node dissection. There's other patterns of recurrence or other patterns of melanoma that I manage clinically on a regular basis. Patients with satellite metastases or in transit metastases, and from a staging standpoint, we just kind of lump them all together. But we manage these patients differently, and as you all know, and I'm sure will be talked about, there's a ton of new options for this in transit disease pattern. But in our practice, in real life, in patients who present with one isolated in transit metastasis, usually we manage them with surgical resection and then discuss adjuvant therapy currently until maybe they're going to fail. They're recurring too frequently to fail that. But surgery is still kind of a mainstay in the management of this pattern of disease. But we do have more local therapies. Here at the bottom I say intralesional therapies, and TVEC is one representative FDA approved, but there's a ton of new intralesional therapies coming down the pipeline. And the regional therapy options, I would say, in the surgical world are kind of falling out of favor. We used to do these a lot more when we didn't have as many systemic therapy options or intralesional options, but it's still an option for those patients. And this is old data. This is from, so this doesn't represent the new numbers, but the idea is just to say that as the stage goes up, the risk of recurrence goes up. And this is sort of a preface or an introduction to what Dr. Weber and Dr. Amaria are going to talk about a little bit later in terms of adjuvant and or neoadjuvant approaches, that surgery can cure early stage disease, but there's clearly a group of patients, both the high-risk stage 2, which are sort of underserved at the moment, and the stage 3 patients who really can benefit from additional therapy. And so to drive home this point of what we were talking about earlier, I truly believe this is a multidisciplinary approach. We all work together, and I would say, the ground is shifting under our feet. We're still figuring out how we should be practicing in this era. It's very uncomfortable for the patients when we tell them this, but it's very fun for us because I think we're still just trying to figure out what's the best thing to do for each individual. And clearly, and again, a lot of this discussion today, so I won't have to belabor the point, the current therapies have changed the landscape, right? I am allowed to be more surgically aggressive now because my patients are going to live longer. They've got a shot. And so where we integrate surgery into these patients that are now living much longer with these important systemic therapies is a real open question. Again, Dr. Weber is going to talk about adjuvant therapy in melanoma, but it really has been a game changer. We went from interferon, which some institutions wouldn't even think about, we still used it, to all these exciting new adjuvant therapies. But how to incorporate that into practice and how that fits in with sort of our surgical window is still in flux. I know that Dr. Amaria is going to talk about the neoadjuvant therapies, but I will tell you at my surgical meetings, this is taking up a larger and larger portion of our discussion of melanoma. A huge amount of discussion. The neoadjuvant approach is great because you can test out the biology, but there is some signal that maybe it's actually better biologically. Maybe you get a more diverse immunologic response when they sort of in situ vaccinate or the immunotherapy is the patient's exposed to therapy while the tumor is still there. And again, I won't belabor this point because I know that Dr. Amaria is going to get into this a little bit later. But again, both in preclinical models and in the clinical studies to date, there's a really exciting signal that there's some benefit to these kind of approaches. There's a lot of interest in neoadjuvant immunotherapy, and again, I know that Dr. Amaria is going to have a whole section on this, so I don't want to belabor the point. But I would say that toxicity versus efficacy really matters in my patient population, right, in this earlier patient population. So as we've adopted adjuvant therapies, as we're thinking about neoadjuvant trials and neoadjuvant therapies, we really have to start thinking about how to balance toxicity with efficacy, because most of these patients, or a large proportion of these patients, are surgically cured. And so this risk to benefit ratio is very important, and I think I would argue more important than patients who are either going to die of their melanoma or not, and they're very happy to take on the toxicity. But in this patients where you're treating a subset of cured patients, we have to really be thoughtful about it. So people have been talking about dosing regimens. There's some interest in smaller or single dosing, like a single dose of PD-1. And the other beautiful thing about these neoadjuvant approaches is the pathologic response can be a surrogate endpoint, clinical endpoint for subsequent response. So that's just a little preview of what you're going to get in more detail later. But the reason I mention it is that all of these changes are factoring into how we think of managing patients. And another big question that's open in my field is who do we operate on in the stage 4 setting, right? So there's patients who are living longer, patients with stable disease, oligometastatic progression, patients who have been responding to therapy. Do they deserve a shot? So consolidative surgery or in oligometastatic progressors, should we operate on them? When I trained initially, it was palliative surgery in stage 4 disease, right? Patients had a bowel obstruction or they're bleeding or things like that. But the world has changed, and again, there's a great deal of interest in surgical oncology in this space. And then the question of timing. Well, if we have a patient who has surgically resectable disease, should we just cut it out and give them adjuvant therapy? Should we give them neoadjuvant therapy? Is there an immunologic benefit in that? And so I would say those questions are still open, but I think they're places that are important. And this is just an old study. This is actually a negative adjuvant vaccine trial, but I like this figure because it's not did the drug work or not, but these are stage 4 patients who underwent surgery and then went on to a sort of a negative trial. But if you look at the 5-year survival, 40% of those patients were alive. And there was some really nice data from John Wayne that had been published a long time ago looking at survival in patients with stage 4 melanoma. And what it tells me is that if you select the right patients, some of them will gain benefit from surgery alone, and even in the stage 4 setting, but how do you select those patients? And I think with immunotherapy in the modern era, we're still figuring that out. And there's, again, a lot of interest. There's a lot of very small single institution studies looking at visceral metastatic resection. Is that advantageous to patients in this setting? We've been looking in the past, and I think now people are interested in looking in this setting of these sort of modern immunotherapies. I would say the other thing that's quite interesting, this is the Checkmate 067, Nivo versus Ipi-Nivo trial, but if you look at the supplemental information, just to kind of look at what the patient demographics, patient population, if you look at subsequent therapy, about 20 to 30% of patients on this trial were undergoing subsequent surgery. We were not really accounting for that when we're looking at sort of their outcomes, but the real life, take-home message is that, in fact, our patients on immunotherapy are undergoing surgery all the time. I have a guy booked for next week. But so we don't really know what the benefit of surgery is in this setting. We haven't really tested it out sort of in a very rigorous fashion. But the real-life fact is that we're doing more surgery in the stage 4 setting, and we're trying to figure out what the biomarkers are, what the phenotype is for the patients who may ultimately gain benefit from that. So I thank you for your time. I'm happy to take any questions.